My name is Ann Langen. I'm one of the nurse educators here at North Shore. I'm also the co-chair, along with Jessica Antretta, the co-chair of our Research and EBP Council here at North Shore. So November is Research Month here for Nursing Grand Rounds, and we try and bring to you some of the activity that's been going on in our facility related to research and EBP. And today, we are very proud to share with you some of the work that's going on here and the initiative that's going to be going on at the system. But we're first, so we're the best, right? All right, I'm going to introduce our first two speakers to you. Cara Bain is one of our senior speech language pathologists who is very passionate on oral care. And we've worked together to bring this presentation to you today. And I also have Max Amestigi, one of our registered nurses from the surgical ICU, giving the nursing perspective. So it's a combined interdisciplinary effort today. Come on up. Choking.
Hi, everybody. Thank you very much for coming. I'm super excited today to introduce our guest speaker. But first, I want to talk a little bit about what we're doing here at North Shore. We have been working on an oral care initiative to address pneumonia prevention and patient care. And Max is going to talk about it again, like Ann said, from the nursing perspective. Okay, so this is what has inspired the work that we're doing. I'm sorry, a lot of you are eating lunch. I wanted to just kind of start things off with this is why we're doing this, right? So there are a lot of reasons, including infection prevention and that sort of thing that our expert is going to be sharing with us and discussing from her level of expertise. But these are the reasons that I got interested in oral care because these are pictures that were taken by myself, my colleagues here and at another Northwell hospital. So these are not out of textbooks. These are from our own patients. This one I want to highlight for a moment because this is the view from inside someone's throat. We do our FEES swallowing exams where we use the nasal endoscope in the nose and we feed people and see if they're safe to go on an oral diet. We were concerned that this person was maybe not managing their secretions and we scoped them and this is sort of what we found. And this is potentially a real problem, right? If this piece of mucus kind of breaks off and falls into the airway, which is what we see on that left-hand side, that's the open trachea, right? So if this falls into the voice box, into the larynx, and blocks that trachea, then we end up with someone who potentially needs to go to the ICU, be intubated, or if somebody's DNR, DNI, there's not much we can do. So it's not just about comfort and fresh breath. There are a lot of other components, but certainly dignity is an important part of that as well. So we, from the North Shore Oral Care Initiative, kind of started out with like, what can we do? Like, we're seeing this problem. What is the degree of the problem? What are we doing? What's our practice like? So this was a couple of years ago. This data was collected. It's been a very long process. We did a quick survey of 3 units. And we talked to nurses, we talked to patients, we went into the rooms and kind of looked in the drawers and on the tables to kind of see where are we, where are we, what are we doing? We found that approximately half of the patients had the appropriate supplies and had actually brushed their teeth in a given day. So that's half of our patients are not getting their teeth brushed, not getting appropriate oral care. There are a lot of reasons for that. And it's not just a North Shore problem. It's not just a Northwell problem. It's a nationwide, worldwide problem. Until people really address it, this is not out of the ordinary. So this is not about accusing anyone. This is about where are we? How do we make this workable? And how do we do better? We had patients that had been in the hospital for up to 10 days. Without a toothbrush. We had independent patients without a toothbrush. We had one hospital employee that came up to us after we'd done this survey who was telling us, that she had been in the hospital for an unplanned or for a scheduled surgery, had some unplanned consequences, ended up with us a little bit longer and hadn't had her teeth brushed for almost 2 weeks once she realized kind of where things were. And we always um, take good care of our patients, but we try to go that extra step for our own. So if we're not going that extra step in that way, in this particular case, then we're missing something. Um, we also sent those toothbrushes off to a lab and had them tested. 48% were colonized with clinically significant bacteria. 20% tested positive for one or more multi-drug resistant organism. And we didn't only tested for 5 organisms, right? So we've been working to try to improve our practice. We have we've had rollout of an oral care kit in our ICUs. I've started training onboarding PCAs at IFN. And then I'm in the process still of recruiting oral care champions. We're going to have our first meeting in December, so please sign up and join if you are able and interested. And then Northwell system wide, we pestered enough people that we got some attention, and we have now had approved a Northwell wide standardization of a process for our oral care products and oral care education. It's all in the works, but it's going to be rolling out here at North Shore in January. So December is a great time to get in to the oral care champion game to kind of learn what's coming and be prepared to be a resource for your floor. And now I'm going to introduce Max, who's going to talk about this from the nursing perspective and his experience in the ICU with the new kit.
Great, thank you, Kara. So just to speak briefly about the the rollout of and the implementation of the oral care initiatives that we're doing here. I really just started to think about, why is oral care important? Obviously, we saw those pictures. It's horrible what can happen to somebody's oral cavity. And the complications that can happen from that are obviously, pneumonia, mucus plug even. There are really, really important things to consider when discussing oral care. We focus a lot on suctioning, making sure our patients' airways are clear, but then there's another step to it where, oral care should really kind of be considered more of an intervention that we're doing to take care of our patients than just something that's part of their hygiene and something that's part of their, regular routine care. It's something that really can be a nursing and a medical intervention to help promote their livelihood. And it really could save their life, as we've seen from those photos. Now, just to speak a little bit about the rollout of our oral care kits, as Kara said, we rolled out these oral care kits in the ICUs and the RCU. The focus on them was for our vented and trached patients so that we can do oral care every 4 hours. There are 6 steps on it with the 2 toothbrushes and oral swabs where we do oral care every 4 hours. And it's very, very simple to use. And it's a good reminder to do our oral care on our vented and trached patients, which are a very high risk for ventilator-associated pneumonia. But in addition to that, they can be used in any patient. Especially, I like to use it in patients that have an altered mental status, that aren't able to take care of themselves, because being on top of their oral care, maybe their mouths are wide open, and they're not, maybe they're MPO and they're not using their oral cavity for anything to do with food. So they have a very high risk for developing bacteria and colonization. So being on top of their oral care is extremely important. So really, the goal with this and with the Oral Care Champion program is to really implement these protocols across the hospital in order to promote oral care for all patients. Now, I've seen a lot of barriers and I've seen a lot of challenges in this implementation and in this rollout. A lot of nurses have stated that there are time constraints during a 12-hour shift to perform oral care on these patients every 4 hours, which is fair, which is valid, because we have a lot of things to do during a shift, of course. And every time something is rolled out, it can be difficult for nurses to do because generally nurses are the people that are at the forefront of doing these interventions that are newly implemented. So there is a lot of resistance to change, of course, resistance to change in practice. I've seen a lack of awareness of these complications. People don't really realize how bad it can get, but it's real. And then also with patients being on anticoagulation, they're at high risk for bleeding with aggressive oral care. So it is very important to, consider softer oral care, gentle oral care. in order to not cause bleeding in the mouth. Now, there really needs to be a personal component to me in this oral care implementation and oral care rollout, where in order to really change the culture, to make it more patient-centered. It's about preventing pneumonia. It's about their comfort. It's about preventing their bad breath, and it's about just promoting oral hygiene overall. As I said before, is truly a medical intervention. Um, Now, just to be really, oral care can be one of the main things to promote as a patient advocate, because a lot of patients that need assistance with their oral care can't do oral care themselves. They need us to really help them to perform it and to do it effectively. Um, so it's really our jobs, it's everybody's job here to make sure that every patient is receiving the care that they deserve, because oral care is really part of that full dignified care package in a way. All patients truly do deserve access to oral hygiene tools, and we have them here. So it's really just up to us to use them and to go ahead and help them clean out their mouths. Now, um, I've seen positive change with these oral care kits that we've rolled out. I've seen a lot of nurses start to use them more and more, just as part of their practice. I've implemented it with my assessments that I do every 4 hours, because it's just convenient to do it at those hours. So there is always time you could find. It's just a matter of getting in the right mindset to do it for our patients. And that's all I have. So I'll hand it back to Kara for our introduction.
So I'm so excited to introduce our guest speaker today. I've been reading her articles for a few years now, and she's uh, literally written the guidelines. She's the first author on the American Association of Critical Care Nursing guidelines for oral care and endotracheal tube care. So she's very knowledgeable. She's a well-established researcher in this area. Just to read her official bio, she's a board certified adult clinical nursing specialist and has been a fellow of the National Association for Clinical Nurse Specialists since 2020. Dr. Quinn has 30 years of experience as a registered nurse and 16 years of experience as a clinical nurse specialist using evidence-based practice and the science of process improvement to impact patient outcomes. While working in a variety of specialties within the acute care setting, Dr. of Professional Practice and Nursing Excellence for Sutter Health System in California for 24 hospitals, and she continues to research, educate, and consult, emphasizing nurse-sensitive outcomes such as prevention of non-ventilator hospital-acquired pneumonia, and that's why we're here today to talk about oral care's prevention of that non-ventilator associated pneumonia. Come on up. I just realized. I just realized that this is not on the presenter view, so I wanted to get that for you. Sorry, guys, just 1 second.
It will.
Sorry, guys. Sorry, we're just trying to get it on. Okay. It was not.
And then,
Perfect. Thank you. Sorry.
oh, now they're seeing. There. Might have been the display. Right here. No worries. I don't need no stinking notes. I am so excited to be here. I have to tell you, we were chatting earlier about COVID and some of the things that we've all been through. In fact, I saw pictures of what this auditorium used to look like during COVID. Were you guys here during that time? Raise your hand if you were here. When there were no chairs, it was just beds and gurneys and oh my gosh. Can you believe we all lived through that, didn't we? Amazing. And here we are, and I'm so happy because I get to be in person with people in person instead of over a screen all the time. So this to me is a real privilege. And anytime I get to talk about preventing harm to patients, it makes me happy. So even though I retired a few years ago, this is what I do. I call it my preferment. It's not retirement, it's preferment. Now I only do what I want to do. And being here with all of you is one of those things. So thank you for the privilege. So today we are going to talk a little bit about preventing hospital-acquired pneumonia. Not sure how much time we'll have on the knowing to doing piece, but we'll see how we do. Before I start, just a few disclosures. Yes, I am a clinical consultant and I am on the speaker bureau for Stryker Sage, who is helped sponsor this and is helping with the supplies you guys are getting for oral care. That's going to be very exciting. I'm also a research grant recipient from the same company. Sage was actually the first company that gave me a grant so I could do a study to see what the incidence and outcomes were for non-ventilator hospital-acquired pneumonia. So I'm forever grateful for that company because they really stand behind nursing and evidence-based practice. And of course, this presentation is available through them. So 3 objectives I think I'll have time for. The 4th, I'm not sure, but for sure we're going to talk about what the significance of hospital-acquired pneumonia, why it's important for us to be aware of it and how to prevent it. And to do that, we're going to describe the etiology and what causes pneumonia, including hospital-acquired pneumonia, and talk a bit based on that, how do we prevent it? And part of that will be identifying the most updated evidence that we now have on how to prevent hospital-acquired pneumonia, things that you can do here at your hospital. And if we have time, we'll talk a little bit about implementation. So let's talk a little bit about significance of hospital-acquired pneumonia. There. And I'm going to share numbers with you because how many of you really like numbers? Like you just geek out on it? Oh, good. I'm not the only one. Yes, but there's also a real human element to hospital-acquired pneumonia and any patient harm that happens, right? So I wanted to start with a story, a true story of a patient, not a real name to protect her identity, but just to illustrate the impact that non-ventilator hospital-acquired pneumonia can have on our patients. So there was a gal, she was 57, and she was admitted for an elective surgery. So I'll call her May. So she came into the hospital knowing she was going to have surgery. Those are pretty much our healthiest patients, right? Not an emergent case, but they come in, they're ready to go and have their surgery. And she did fine during surgery. She was taken out to the med surg unit and she did quite well for the first day or so. Day 2, she spiked a fever. She complained of a cough. She had some productive sputum and she needed to be put on some O2 to keep her above 92%. So what are you guys thinking? Right, pneumonia? Right, I guess that's what we're talking about. Good guess. So of course the doctor ordered all the tests and sure enough came back positive for a hospital-acquired pneumonia, not related to a ventilator, which by the way, 70 to 80% of all hospital-acquired pneumonia occurs outside of the ICU. So just keep that in mind. So she got worse. She was transferred to the ICU. She went into septic shock and she passed away. This was a true story. And that was one of 100 cases that I reviewed over a year's time to see, do we have a problem at our hospital? And so the resounding answer to that was, Yes. Yes, we did have a problem. So that's the human element. Every number that I'm going to talk to you about has a patient story and a family that's been impacted. So we're going to talk about numbers and we're going to geek out over them a little bit, but we can't forget the humans right behind it. So back to the numbers. The last point prevalence study that was done in the United States was done by the CDC, a researcher named Shelley McGill. And every so many years, they do a study. They survey about 199, 200 hospitals across the country, and they do a one-day prevalence study. So it's like a snapshot in time. And the latest one that was published in 2018 found that for the first time, pneumonia was the top #1 hospital-acquired infection in all of the United States. That means that 1 in every 4 hospital-acquired infections is pneumonia. And you can see on this next slide, 2/3 of these cases are not from ICU. They're not from being ventilated. The majority of pneumonia, like we talked about, occurs outside of the ICU. Very important to remember. So what does the impact look like to our organizations? Of course, the impact to patients, impact to all of you, because you have to take care of them when they get sicker, right? So this is sort of a summary slide that I put together to give sort of a big picture about the impact to patients and organizations for non-ventilator pneumonia and ventilator-associated pneumonia. So the impacts you can see, incidence, mortality, et cetera, down that left-hand side. That middle column is VAP, so you can see mortality, for example, as high as 23%, length of stay,
How's it going,
costs.
Carlos?
So instead of reading this off to you, what I thought I would do was share one of the newest studies, very large study that gives us examples of the incidence and outcomes of hospital-acquired pneumonia, specifically non-ventilator, because that's the majority of cases, right? So that's the one we really need to learn more about. So they looked at data for 284 hospitals, I think, all of the VA and all of the HCA hospitals, over 2 years of data. They looked at 6 million patients, analyzed that data. Of those patients who got well, let's see, how many got NVHAP? It was about 1 per every 100 patients admitted got pneumonia. Of those who got pneumonia, non-ventilator associated, 22% mortality, 22.3%. And that's crude mortality, just all cause mortality. 7.3% of them their mortality was directly attributed to NVHAP. So just because they got pneumonia in the hospital, they passed away. That was that. The length of stay was an average of 14 days instead of 2. For patients without NVHAP. So that's pretty significant, right? Dr. Baker and I also did another 21 hospital study. And we looked at all these things and found very, very similar, almost identical information on incidence, mortality, and length of stay. What we also looked at was other outcomes like 30-day readmission. How many of you guys are trying to reduce your readmission rate? Yes, it's a huge one, right, on our organizational dashboards. We found that 1 in 5 of these patients who got NVHAP had to return to the hospital within 30 days. That's really significant, and that can come to bite us at reimbursement time from CMS. One other thing that's not on this chart that I think I need to add is ICU utilization. How many of you guys have more than enough ICU beds? Raise your hand. You never need ICU beds. You always have more than you need. Oh, no? Guess what? You're not alone. I've asked that question all over the country. I've never found one person say, oh, we have way too many ICU beds. We can't, there's not enough patients to put in there. No. So what we found, patients, first of all, 1/3 of hospital-acquired pneumonia patients that not related to a ventilator occur in ICU, in patients not on the vent in ICU. They're 2.5 times more at risk to get non-ventilator pneumonia if they're in the ICU and not on a vent than a med-surg patient. That's one. They start out in the ICU. Then that 80%, 70 to 80% of NVHAP patients out on our med-surg, tele, oncology, ortho, all those units, a third of them have to be transferred to a higher level of care because they get so sick from the pneumonia. That means that about half of all NVHAP patients spend some time in our ICUs. If we could prevent pneumonia, what else are we going to impact? Look, if we reduce the incidence, do you think we can reduce mortality? Can we reduce length of stay? Can we reduce cost? 30-day readmission, ICU utilization? Yes. That's why I really focus on prevention, because I think that is the upstream way to start looking at this. And then there's sepsis. How many of you guys hear the word sepsis and early recognition and treatment and all of that? Yes, it's a big thing right now because why? We have to report something, right? But what are we reporting? We're reporting the bundle. We're reporting how quickly do we notice it? Do we do all the things to treat it, right? Did you know that the #1 site of infection for septic patients is respiratory? Pneumonia. Pneumonia is the #1 cause of sepsis. Now, not everybody who gets pneumonia is septic, but what we do know from the studies, up to half of patients who are septic, the site of infection is pneumonia, respiratory. Again, our focus is with sepsis, is on early recognition and treatment. What would happen if we were thought upstream, right? And we're proactive and said, let's think about what's the best way to prevent sepsis, prevent pneumonia. That's right. You guys get A's. And guess what? This data is not a secret anymore. So you can see from this slide that NVHAP is a growing concern across the country with CMS, with infection prevention professionals, all of these things. These are just a few of some of the big statements, call to actions, practice position, prevention things that have come out. And you can see in 2021, see that orange one, quick safety? Who do you think put that out? Joint Commission. That's right. And when Joint Commission speaks, we better listen, right? So Joint Commission says NVHAP is a big problem. It's killing patients in your hospitals. Every hospital should be monitoring and measuring and should have a program in place to prevent it, including evidence-based oral care. So I'm standing up here super excited for you guys because you are already ahead of the curve. Many hospitals are not where you are yet. So that is a good thing and something to be very proud of. And then there's the total publication numbers. I was telling somebody earlier, in the last 5 years, there's been over 70 publications regarding NVHAP, and you can see how it's grown exponentially over the years. So it's definitely something we should all be taking seriously. So we know that it's a problem. We know it's impacting our patients, families, organizations, all of you and your roles. So why is that? Why is it happening so much? I wanted to take just a quick look at the etiology, what causes it, because we know if we can identify the causes, then we can put prevention in place. There's really 3 mechanisms, and this may be oversimplifying slightly, but not very much. You need the pathogens that are aspirated and get into the lungs in a patient who has poor immune response and poor physiologic response. If the germs get in the lungs, they can't fight it off for whatever reason. We see this a lot, don't we? The CDC says the best way to prevent pneumonia is identify those most modifiable risk factors and put programs in place to prevent them. I'm going to name a risk factor and you tell me if it's modifiable or non-modifiable. Risk factor for pneumonia is elderly age, high age, old. Non-modifiable. We cannot fix that, can we? What about if a patient has a comorbidity like heart failure? Non-modifiable. Oh, what if they have a what if they have a swallow impairment? It's a little bit gray, isn't it? Okay, that's right. Aspiration will never be eliminated. We can reduce it, but we can't eliminate it. So that's partially non-modifiable. Okay, so you get the idea about that. So let's look at why our patients are at such high risk. Why are so many of our patients at risk in the hospital? Why is it happening so often? Again, I want to go back to pathogens in the mouth. Remember that the pathogens that cause pneumonia start in the mouth. 24 to 48 hours after hospitalization, pathogens that live in the hospital, all the ones we talked about that we saw in the toothbrush, microbial contamination in the toothbrush, those are all hospital germs. Once a patient is in the hospital, even 24 to 48 hours, those already are starting to live in the oral microbiome, sort of that, all the germs or the microbes that live in the mouth. This slide on the left is one of my favorite because it helps us visualize what we can't see without a microscope. But it tells you what happens in a mouth without oral care in the hospital. You see on the top left-hand side, those little red things, that's bacteria. The majority of pneumonia is caused by bacteria. You can see over time that there's more and more of those red things. Exponential growth, that yellowish orange, that's that sticky biofilm that sticks it all together on the teeth, on the tongues, on the sides of the cheeks. This is what happens without oral care in one shift. You can see how just even a tiny bit of that, even 1 ml of saliva holds up to 100,000 microbes. And if there's bacteria in there, it will slip right into the lungs. So let's talk about aspiration. Aspiration, it's impossible to eliminate aspiration. There's studies that show even healthy people microaspirate. Are your patients healthy when they're in the hospital? No, it's a contiguous route from the mouth to the lungs. We used to think that the germs, the microbiome in the mouth was totally separate from the microbiome in the lungs, but that is simply not true. Now we know more. Basically, whatever's in your mouth will also be in your lungs. Studies have shown that patients with hospital-acquired pneumonia that have a culture done, it matches to the perfect DNA of the same germs that were in the mouth in that patient. So we know that that's true. So who really is at risk for hospital-acquired pneumonia? Think about those pathogens. Which of your patients are at risk for those pathogens that cause pneumonia? We just talked about it. Everybody who's been here 24 or more hours, they're at risk for those pathogens, right? Who's at risk for aspiration? Even healthy people microaspirate, and then we lay them down, we give them medicines to make them sleepy, or they have surgery, we put tubes down them, make them even more at risk, right? So I would say everybody is at some risk for that aspiration or microaspiration where saliva could slip down. And then which of our patients are at risk for being a weak host and having poor immune defenses? You look at this list, who isn't at risk? That's what I ask. In fact, I like to say that although some hospital patients are at higher risk of pneumonia than others, all patients are at some risk. And that's why I always recommend to hospitals that are working on this that there should be a standard of care, a standard of pneumonia prevention in place for every hospital. Just the basic things should be done for everybody. So what does that pneumonia prevention look like? This is a prevention driver diagram that was published in the APIC implementation guidelines for NVHAP prevention. I just changed it just a little bit for you, but you can see the aim in this. If you look on the right-hand side, the aim is to prevent possible acquired pneumonia. So that's VAP, VAE, and NVHAP. How we get there is those three primary drivers in the middle. Those are those three mechanisms that we need to directly target. We know these are the three things that cause our patients to be at risk. So that's where we need to focus our attention. Look for those modifiable risk factors, right? So we start at the bottom, look at strengthen host defenses. Can we strengthen host defenses? Yes. The evidence on the left-hand side, those secondary drivers, we know that if we can get them up and out of bed and moving, they are less likely to get pneumonia. If we make sure they're getting all their enteral feeds or use it in the ICUs, we can increase their resilience, right? Glycemic control. These are three things that are in the literature everywhere. We know we can do to help reduce the risk for pneumonia. To reduce aspiration, remember, I'm not saying eliminate aspiration, but there are things in the evidence that we can do to reduce that risk. We can identify dysphagia early, do those bedside evaluations, RNs. And remember, they're not just for stroke patients. Anybody could be at risk for aspiration. You don't know if they're dysphagic if you've never seen them before. You know, have them, you know, do that bedside swallow screen just to make sure and get those referrals done. Elevate the head of the bed. Again, elevating the head of the bed will not eliminate risk, but it will reduce it, right? And of course, avoiding intubation and minimizing sedation. We know that's important to reduce the risk of aspiration. Today, we're going to talk mostly about oral hygiene because this is an oral hygiene program, and so we want to focus on that. But there are some other really good reasons that if you want to prevent pneumonia and you want to start somewhere, this is probably my #1 recommendation, and this is why. Oral hygiene is the only intervention, the only strategy in the literature that addresses source control. Where do the germs start? In the mouth. Doesn't it make sense that if we want to look for something that is the most modifiable, that is actually where the germs start that cause infection, isn't that a good place to start? There's the most evidence on oral care. It's the most effective compared to other things. It's low risk. It's low tech. It's low cost. We were looking at toothbrushes in here in the other room, and there's a little suction toothbrush we talked about putting in place in some of your, like a one-time use thing. It costs less than $1. A prevented pneumonia will save $40,000. So even though the toothbrush may cost a little more than we're paying for those, I don't know if you guys have those really horrible hard toothbrushes where the bristles fall out. Oh my gosh, nightmares about those. Yeah, we'll pay a few more cents for our good toothbrushes, but the return on investment is amazing. Plus, you're going to spare a patient like May from getting sick, having to stay, or even dying, right? This a couple years ago, oral care was added as an essential practice in the updated guidelines from SHE. So that was big. They also added NVHAP to the title of those guidelines. The first time ever they've included non-vent pneumonia. So that just goes to show that we're on the right track if we're really pursuing prevention. So I have to say, yeah, there it is. There it is. Oh my gosh. Not all oral care is created equal, of course. So what does oral care, evidence-based oral care look like? I will say when we started this research, we went to the American Dental Association and we said, you know, nobody knows this better than our dentist friends. And so this is the list of just the basic standard. You shouldn't go any lower than this. And every patient should have this at least twice a day. So a small soft bristle toothbrush, soft bristle, not that other one. Therapeutic toothpaste that actually helps remove plaque and break up that biofilm. An over-the-counter, alcohol-free antiseptic mouth rinse, petroleum-free, no Vaseline, please, uh, mouth and lip moisturizer. If you have patients who are at risk for aspiration, you should have suction toothbrushes available on every floor. They're not just for ICU ventilated patients. And then if your patient has dentures, you definitely need to have denture supplies. But just remember that denture care does not eliminate the need for mouth care. We still need to clean their mouth. Patients without teeth can still get pneumonia. I don't want to forget that. Um, we also know that supplies is only one part of a good oral care program, and I don't have time today to talk about everything, but you need to have policy and protocol and all of those things to help you. So I do want to just mention a few things to use some caution with. One is the swab. We love our swabs. Don't tell me you don't. We love our swabs. Just a few things that I want to give you a heads up on. I know I had some poor practices when I was at the bedside because I didn't know any better. So now I know better, so now I do better. But swabs sitting in water at the bedside, we just should not be doing that. The swabs are one-time use. They only cost about a penny, I'm told. So take a handful. They should be individually wrapped so they don't get dirty. Open it up, use it, toss it, right? You don't want to put it used and leave it sitting, I call it swirling in the water with the bacteria biofilm floating on the top. Oh my gosh, it's so awful. And I know that I did it too. But anyway, we know better, we do better. Also, we don't want to leave it sitting in the water because, you know, the glue that sticks the sponge to the stick can actually soften over time in the water. And in Europe, they actually have banned some of these, not this type, but a different type they banned because of choking hazard. So one-time use only. The other thing I want to make sure to say is that sponges are great, but they do not replace brushing. So remember that sticky biofilm on that slide that I showed you? That doesn't come off with a swab. You need to brush it, disrupt it. It can't just come off with rinsing. It can't come off with just a little sponge. So you want to make sure that you're brushing your patient's teeth at least twice a day. You can swab in between, you can moisturize, you can dip it in water one time and moisturize. That's all fine, but it should not be used as a substitute for toothbrushing. Just wanted to say that. Lemon glycerin swabs. Do you guys still have these? Do I need to talk about this? Good. Oh, I need to go back. Chlorhexidine. Oral chlorhexidine oral rinse has been recommended since 2010 when we started the ventilator associated pneumonia bundle. In 2022, there was one US guideline that dropped it from its recommendation, but there is a brand new study that just came out, a pretty high level study that says it's still a little bit on the fence because the studies that have been done are different concentrations, nobody's looked at it exactly the same way. So I would just recommend that if you're using chlorhexidine or changing your practice, that you make sure you're following your outcomes. We just want to make sure that when we change a practice, that we're not impacting our patients in a bad way. I am happy to tell you that prevention works. So remember on that driver diagram, I showed you all those interventions. This is an article about a big hospital system in California that put all those things together, and they were able to, they saw a statistical reduction in the rates of pneumonia, a reduction in mortality, and a reduction in broad spectrum antibiotics, which is also antibiotic stewardship's also something that we're
I gotta
really
go.
interested in. So the good news is it does work.
To get
So
gas, to go get
I
my
don't have a
room,
lot of time
to have
because I want to
medicine.
make sure you guys have a chance to have comments or questions. But I did want to talk just briefly about how to get, so, I mean, I think everybody in here, it's like, yeah, we understand it. Hospital-acquired pneumonia is
Hey, boogies.
significant. We need to do something about it. We can
And
do
then
oral
this is
care. We're
good.
getting new equipment and we're going to put this in place.
Mhm.
It's
my
what's
window.
hard, I think, is to get from the
Window.
awareness and knowing,
What, this?
yeah, we should be doing
That's from
this,
him.
to actually
guys.
getting it to the patients. One of the things that Kara was showing us is, you know, that only half of the patients even got their toothbrushes, right? And I got to tell you, we see that all across the country. Even when people will attend something like this, it's hard to get it into our daily routines and make sure that all of our patients get oral care every day, right? So I've done some work on how to get from knowing
Thanks.
to doing. And
Where should I get gas? Does it matter?
that is called implementation science. And I know that sounds complicated, but it's really just like a map of how to get from where we are to where we want to go, right? 50% of patients with toothbrushes to 100% of patients with toothbrushes, to brushing once a day to brushing twice a day, right? Those are all good goals, but it takes a little bit of a plan to get there. I'm not going to go a lot into this, but implementation science, right? It's that deliberate process. It starts with assessment, just like all of our nursing stuff. We start finding out where we are. It's not just products. I mean, that's a really good place to start. Find out where your staff is. What do they know? Do they know this is a problem? Do they care about it? Do they have everything they need? You do that pre-implementation, then there's some project management. And the big one I think that we struggle the most with is change management. So how to get from information to practice. This is really the people side of change. How do we get everyone to change behavior? How do we change our behavior? I mean, everybody in this room that I'm looking at or listening, who's listening online today, the only person you really control, the only practice you fully control, talk about modifiable things, is your own practice, right? So when you leave today, most of you are not practice change leaders, although if you are, you know who you are and you know how to do it. But if you are a staff nurse, the only person you can control is you. So I would encourage you to, now that you're aware of this, you can go talk to your peers, you can make posters, you can make sure that all of your patients get their teeth brushed, and then work with your leadership as they continue to roll out this program. I'm going to show you just a few examples. When we did this at my pretty large hospital, we had some really good results. These are just a few of the ways we did it, and they're probably things that you guys could do something like. Just some ideas, lots of different things we can do. But one of the things we learned from our staff in our pre-assessment was they felt like patients on their unit were their patients. Like they felt really responsible for their patients. I'm sure you guys are the same way. So what we did was we collected data in a way that helped the staff on each unit understand how frequently their patients are getting their teeth brushed and what their incidence, how often their patients were getting pneumonia. And then we put it on a graph and we did one for each unit. And then if we had a breakthrough case, we would tell the story. So for example, this one, they had a 64-year-old patient admitted for an esophagectomy because of cancer, and then was there for a long time and came down with pneumonia. So we told the story. We also looked at the chart to see what the oral care was, how much they were out of bed and those things. So they got really good feedback. This was really helpful to them. I'm not going to go through all the details on this because I want to tell you one last story. But we did things to help staff be successful. So this is one thing we put this, the protocol, we put it up in color. We even put pictures of the supplies that we were using at the time. The procedure, the frequency, we laminated them and we put them in the supply rooms. So when our PCTs would go in to get oral care, they would know exactly what to pull for patients. So it's just an example of things that we did. We did classes for our PCTs, and I heard you guys are already doing them, so I'm super excited about that. They were our best champions. Once they learned that their actions could save lives, they were all over it. They were really excited to feel like they were a really important part of the team. Again, more data. We did. Are you laughing at me? You notice in this picture, I'm not the one with the costumes on, but we made it really fun. We gave cakes to the best units for increased oral care. Every time we presented our data to the big wigs in the hospital, we would dress up or throw toothbrushes or whatever. We just had a lot of fun with it. I did do a conference once where I wore a tooth fairy costume, but I gave it to my granddaughter, so I can't do that anymore. So you had to miss out on that. But we made it fun. And of course, make it easy for the nurse to do the right thing. Make it easy to document, make it easy to put the supplies at the point of care. I mean, there are a lot of things we can do to make life easier for you. So just in summary, pneumonia, of course, it's the #1 hospital-acquired infection. So super important. We need to do something about it. I think everybody's understanding that now. Everybody in the hospital, all patients are at some risk, right? Because of the 3 things we talked about. And the pneumonia prevention strategies, we really want to focus on those risk factors that are modifiable, right? And for successful change, we need to use models and scientific strategies to get the change into practice. I did want to share one last story with you before I close. And I think it's difficult when you're preventing something. I mean, it's easy to tell a case study when somebody gets pneumonia. Oh, they got pneumonia. Oh, and here's their story. But if they don't get it, where's the story, right? So I do have one of those stories. I was approached, and this story came from this patient's daughter. Her mom was 79 when she was diagnosed with esophageal cancer, and she knew the treatment was going to be horrid, but she said, "I'm not done yet." That was her quote. Her daughter said, "I'm not done yet." And so she went through with the surgery. She had a feeding tube, and you guys have seen those esophageal. It's really hard surgery and recovery. Anyway, she got well enough to go home. Super involved family. They were by her side, taking care of her so she could be at home with her husband and her kids and see her grandkids was really important to her. The only problem was she kept getting pneumonia. And she'd get pneumonia, she'd go to the hospital for 2, 3, 4 days, a week, sometimes 2 weeks, get well enough to go home. Then she'd go get pneumonia, go back to the hospital. And they said it just went several times. And then she found an article about oral care to prevent pneumonia. And she says, "Barbara, I just want you to know that this is personal for me." She said, she goes, "I showed the article to my family, and we all decided that it couldn't hurt, so we may as well try." And she says, "We brushed her teeth 4 times every day." And she goes, "I just want you to know that she never got pneumonia again." And I got an email several years later that she was still home and she celebrated her, I don't know, 50th wedding anniversary with her husband. And so it's like, those are the stories. Those are the things that are hard to measure, right? But that's the difference that we make. And isn't that why we went into healthcare? To help. Thank you so much for having me. And I don't know if you guys have time for questions.